And if I can't get to everybody on week 5, because there will be the 2 tests, and I do need to get some key things done in lecture, then yeah. All right. Are there any more questions? Comments? Concerns? Statements? Advice? Predictions? Quotes? Important events? Weather announcements? Nothing at all. I ran out of things. I don't know what else. Nothing at all. You know, I'm going to keep dragging out like this until somebody says something, right? You know how this works. This whole interaction thing works. So I'm kind of need a few people to like respond, and then we'll get going. If not, you're going to miss very key stuff today, because I'm going to go over cardiac like you've never heard it before.
It was just kind of like recovering from test taking, and then the anxiety of like the test not submitting. Still trying to recenter.
Yes, anxiety. Students and anxiety. What are we going to do with y'all? Well, don't got anything for you on that one, because the board is going to be 1,000 times more difficult than these little quizzes are. And if you can't manage it on a quiz with a few glitches, fast forward to practice when you're at bedside. Your client's desaturating, going bradycardic on you, throwing PVCs at you. You're trying to work the room. You got family members like in your ear, like, what's going on? What's going on? You're killing my son. What's going on? You're killing my son. Yeah, how are you going to work that situation? So you're going to get bombarded a lot.
Can you just ask the family to step out if it's like something very crucial?
Yes, very good. Yeah, you can always ask the family to step out. But what about family-centered care? Is that very family-centered care?
No.
Well, when like family-centered care be like during more acute stuff, if it's more critical, like a pediatric code, you want to get in there and have like medical staff around the child, not just like family bombarding the child.
So yeah, we want transparency in healthcare. So we don't necessarily want the families to go. So we ask them, look, I understand your concerns. Could you wait on the couch right there? You can stay in the room, just wait right there. When I finish with your son, I'm going to come back and I'm going to update you. All right. But it is the new practice now, the new practice to keep family in the room during a resuscitation, if possible, because they see all the heroics that have been done. They see we tried everything. And so at the end, when they die, because let's just be real about this, most of them don't succeed, right? If they're going to need resuscitation in the hospital, it means that they're multi-system failure by that point, and we're probably not going to be able to revive them. So when they do end up passing away or expiring, they know that we tried everything was done. So it does help with the transition. So yeah, it is becoming a trend now, not to necessarily remove them from those situations, but it is nursing discretion. So if you don't feel comfortable with them being there, if you feel like they're getting in the way, if you feel like there's just not enough room, some of these rooms are very small, and if you get 9 people in there, well, it becomes a space issue at that point with all the equipment, the ventilator, the med cart. It becomes a space issue. So we don't necessarily have room to have a family member. So it's nursing discretion. No one situation is the same. You can't possibly print something in the textbook and expect every situation to follow that, because each one is unique in its own way. This is why experience in nursing is critical. And that's why most hospitals want a nurse with 2 years experience, because in 2 years' time, they've seen enough situations that the hospital hiring them feels comfortable about where they're at. You're going to really learn the most when you hit bedside. That's where you're really going to learn the most. All right, good. So today, these are our objectives. Our objectives are listed each week on my PowerPoint and or the syllabus. For each week, there's objectives listed. So please follow your objectives for the current week we're in. Definitions are right there. All right, chain of infection. So what is this all about? Well, I'm going to use COVID. At the beginning of the pandemic, you had these individuals in white lab coats get up there in front of national TV and make these statements. You must social distance. You must do hand hygiene. You must wear a mask. You must wear a face shield. And well, they're just quoting the chain of infection. This chain of infection's been around for decades. We know this. we know this, right? So any nurse, LVN, RT could have got up there and did the same thing as these guys. But they walked away with boatloads of money, because some of these guys did updates all day long when the pandemic first hit. And well, they're just they're just stating what we already know. So it all starts with an infectious agent, which is in this case the COVID. And we need reservoirs. Lo and behold, we'll never really find out what happened, what came first, the chicken or the egg, because the so-called originating country is not so fruitful with disclosing all of the key information that we need. So I'm pretty sure it'll go down in history as that one really unknown event, because who really will know what happened? All we need to know is the people became the reservoirs, and the people spread it like flies. And yeah, so we need the reservoir, the people. And then we also need a portal of exit. That's our blood secretions, excretion, skin. That's why we had them wear a mask, so they don't exhale out, right? That's why we had to do a hand hygiene, use the sterilium, use the sanitizer, because we're trying to break that chain. Can't break the people chain. Well, we tried to break the people chain too by isolating everybody, making mandatory lockdown, shutting up. Remember, we shut down all the grocery stores, everything. It was eerie. During the peak of that, when we were mandated to stay in our houses and everything was shut down, the world came to a stop. And so they tried to sequester the reservoirs too, to slow the spread. That didn't really work. So move into modes of transmission. So physical contact, droplet. So again, we tried to social distance, and that's how we tried to break the mode of transmission. We again tried to have everybody wear a mask and break down that mode of transmission again, because it's in droplets. But we do need the portal of entry. This is again why we wear a mask and a face shield. So mucous membranes are the respiratory system is the most conducive to grow bacteria. It's like a petri dish. Our airway is lined with mucus. The mucus is just ready to grow bacteria. It's a warm, moist environment. They get plenty of nutrients, so that's why it festers. But we can also ingest it too, or broken skin. So some way it has to enter your body. Once it gets in, it's still, we need a host, right? It needs somebody, its immune system's weakened. So now you have your clients or your populations of clients that had pre-existing health conditions, diabetes, hypertension, obesity, whatever the problem was, they're the ones that it hit the hardest because they had pre-existing health conditions because they were susceptible hosts. You had the very old, remember it tore through our nursing homes. And then, of course, our very young too. You didn't really hear a lot about our very young. It didn't really get reported as much, but I can tell you the NICUs were inundated too, just the same. So, and then it goes to the infectious agents. So what we're trying to do by breaking the chain is really, in essence, we're just trying to slow it down. We're just trying to slow down the beast. We're just putting the brakes on it until we can get a vaccine made, or if we can get a treatment made. The problem with treatments is it does take a good 10 years to develop a drug from start to finish. So, yeah, and it takes about $1 billion to do so, to get a drug to market. Okay, 1 billion with a B. So it's a little bit difficult. So we have immunizations. So we're going to start with our immunizations. And then in a few years, you're going to hear COVID treatment, really drugs made to battle COVID virus. So antivirals that are designed just to combat COVID. That'll take time. Don't expect that anytime soon. Maybe with the whole entire globe working on it, we can cut that time from 10 years down to 5 years. So maybe in a couple of years from now, we'll see it. But yeah, I wouldn't hold my breath on that one right away. But we can celebrate our immunizations. So our Healthy People 2030 goal is to reduce, eliminate, or maintain elimination of vaccine preventable diseases. And now COVID is under that category because we do have a good vaccine for it. Now, will being vaccinated stop you from getting it? Probably not. In fact, no, it will not. You can still absolutely get it. It just won't do any real serious damage to you. It'll be, if you're going to compare the apples and oranges, it would be like a cold versus the flu. Okay. Reduce meningococcal disease and reduce invasive pneumococcal infections. So immunizations are great. I have a group doing the immunizations today, so I'm going to let them do this. I just want to stop on one thing. Why is it so difficult for our population to understand it takes time to make immunizations? It's not so easy. It's not a perfect science. We do the best we can do, but it's not perfect. Unless you've been sleeping in a coma all of your life, you'll know that we just have about a 20 to 25% efficiency on our yearly flu shots. So there's a lot of scientific predictions that go into this stuff. We predict which way it's going to go, but we don't really know. So it is very difficult to make a vaccine that works because our viruses are smart and they morph and they try to preserve their viral life by morphing and changing. And so we have to keep continually changing with them. But vaccines are still really, 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 really good. But it is hard. There are 5 different major groups for vaccines. And I'm going to leave my group do that one. So when do we give these vaccines? Well, we follow the CDC schedule. On week number 1, I did post up the mnemonics that are very helpful. And you can utilize that one. It still does work. But if you don't have access to that, you can always just download the CDC schedule. Now, there often are times when children or infants cannot receive their scheduled vaccine for one reason or another. So we know we give them at 2, 4, 6 months. And so sometimes at 6 months, they're getting their first vaccines. So what do? Well, CDC has a catch-up schedule too. So even if they were anti-vaxxers and now they're finally going to consent to give all of their vaccines, we have catch-up schedules for everything. And it's all on this on the CDC website too. So you can use those catch-up schedules. Thankfully, we can take these vaccine types and we can group them. So you see that the inactivated has DDaP, Tdap, Hep B, polio. So we can combine a lot of different vaccines in one container, and that way it reduces the amount of pokes that we have to do. So we can greatly reduce the amount of actual injections with these combinations. They're great. But still, you will have to give multiple vaccines in the same extremity. For infants, the vastus lateralis is always going to be the preferred site. If they're 5 or more, then probably the deltoid would be the preferred site. If you're going to use the same extremity, you're going to need to separate those by at least 1 inch. 1 inch. Use aseptic technique. That means when you clean it with alcohol, it's a 20-second scrub and a 10-second air dry. How many people have seen this? Okay. Was that a 20-second scrub and a 10-second dry? No. To be effective for alcohol, the scrubbing, physical scrubbing has to be 20 seconds and it has to sit, let sit for at least 10 seconds. We can give these vaccines if they're a little bit sick, if they have a little bit of a fever, if they're on antibiotics, if they're premature at a stable weight. So these next 3 slides are just for you to know the disease and how it's spread. Because you all will be nurses very, very soon, sooner than you want, or you might think you want it now, but you might regret what you say, because being a student is a whole lot easier than being a nurse. In some cases, you're like, I can't take this. I'm getting bombarded. It seems like some days are just like, oh my God, I can't get out of here fast enough. And then some days you're at Disneyland like, I'm on the best roller coaster here. And then some days you're just like falling asleep because it's so boring. So boring. Like, oh my God, can something just happen? So these next 3 slides are just for you. If you're a clinician at the bedside, you're admitting a client, the client comes positive with one of these things. That way you can recall, you can say, oh yeah, I remember that's droplet or that's contact. So I'm going to put them in that isolation. It's to protect yourself as the clinician and the others around you by knowing the disease and how it's spread. Now, the rest of the information on these 3 slides is really good too, because you get your symptoms and complications from each of these diseases. But my focus for you guys is the disease and how it's spread. And we're going to move right into treating fevers. So most hospitals have computerized charting now. In fact, I want to say all hospitals probably, well, I can't say all because I don't know that for a fact. All right, 99.9% of the hospitals have computerized charting. And those computerize the electronic health records default data, or you can copy and paste data. Okay. It's most of these systems have a protection built in them. So when you default or you copy and paste it, it's not saved yet till you save it somehow. right? And different systems have different ways to do that. And then once it's saved, it becomes part of the permanent medical record. It cannot be changed or altered. If you do go back and unchart, you will still have all of your original charting. It'll just have a line through it, or it'll say uncharted, right? It'll be something, but it'll still be there. If it's taken and put up to the jury and they're going to question you, why did you say this? And then now you're saying this, they're still going to question you. Right. If you're going to be disposed or do a deposition, the prosecutors will pull up your charting. They're going to try to discredit you as being an incompetent clinician. And so if you have charting, you have a lot of charting that you went back and said error. Well, that doesn't really sit well with the jury, and the prosecutors are going to have their day with that. So before you save it, make sure it's real. Before you save it, make sure it's real. All right. There's a reason why I'm saying this. If you get a vital sign and it's not consistent with what other clinicians have been getting, then please do the right thing and repeat it before you chart it. Because once you chart it, it's real. I've seen kids scheduled for discharge Friday morning, and everything was ready. Parents are there, car seats there, they're ready to go home. Overnight, the nurse defaulted something, didn't check it. For whatever reason, it got charted as an abnormal vital sign. Doc came in the morning before they signed the discharge, and lo and behold, saw this value. Once it's on the chart, it has to be treated, even though it was obviously erroneous. But once it's on the chart, it has to be treated. Delay the discharge, put them on antibiotics, do blood cultures. You can see where I'm going with this. It causes these clients that were ready to go home to be now exposed to 3 more days of the hospital environment. And yeah, that's really not a very good situation to be in, especially as a parent. So before you chart it, make sure it's real. Do double check it, because if you do chart it and it's whatever it is, they're going to have to act on it. So that's one situation. Another one is for temperature. If you report anything greater than 38 degrees Celsius, you will automatically get a septic workup, especially if they're 2 months of age. That means a lumbar puncture, blood culture, urine culture, sputum culture. They're going to put them on prophylactic antibiotics right away. Older children, they would do the same, but they're going to put them on ibuprofen, Tylenol, never aspirin because of Raynaud's syndrome, light layers of clothing. We want to do cooling measures. We don't want to induce shivering, and we want to get them fluid. Why? Because it's the immune-mediated inflammatory response to the bacteria. The bacteria is in your bloodstream. It's called bacteremia. And we don't know this because it's an incubation period. So we don't know when we have bacteria in our blood. We were exposed. Did we get it? We don't know yet. We'll soon find out, because they'll go into, if they do truly have bacteria in the blood, they will progress into SIRS. That's a systemic inflammatory response syndrome. This is a widespread immune-mediated inflammatory response. What does this mean? It dilates out the vessels. It opens the pores in the vessels. It allows the intervascular volume to leak out to the extravascular space, which is called third spacing. Causes bronchial constriction, angioedema, right? It causes a lot of things. Your body, your heart's going to try to pump more blood. The heart's going to work harder. Your lungs are going to work harder. You're going to be diaphoretic. You're going to have you're going to be febrile. You're going to be pale because of that just lack of volume. It'll just poof. And yeah, so you're going to see this as a clinician. You're going to say, oh my God, septic workup, right? You'll probably do your septic workup when it hits SEERS, because again, you don't necessarily know when the bacteria is in the blood because it's that incubation period. So you will, when it hits SEERS, you're going to know that those changes happened. You're going to get your cultures. You're going to put them on the antibiotics at that point. Then you're going to have to wait the 3 days for that to grow out. 3 days until the final reading comes out and it says, yes, there is bacteria here in the bloodstream. And then that's the point you can call it sepsis, right? That's SEERS with a documented infection now. At that point, you can actually call it sepsis. That point too, we might change antibiotics because when you get your cultures, it'll have sensitivities, and the sensitivities will tell the clinician what that bacteria is most sensitive to. So Ken, we're going to maybe start them off on something broad spec, like maybe vancomycin, maybe something else. I don't know, fluconazole, I don't know, whatever. Maybe we'll start with Ampingent. Who knows? We're going to do something broad spec to kill both gram-negative and positive. Okay, rods and cones. We're going to try to cover everything. We don't necessarily put them on antifungals unless they're suspected to have a fungal infection. So we'll put them on these broad spec antibiotics, but when our sensitivities come back and it shows maybe this bacteria is more sensitive to this thing, they might change it at this point. So hopefully, fingers crossed, we can stop it at this point, because if it goes into severe sepsis, then Houston, we got a problem. It's a problem for the client, but all of my ICU nurses here, my ER nurses, my trauma nurses, my future ICU critical care nurses, this is when your mouths start watering. You're like, oh yeah, now it gets fun, because now you get to just do it. You get to use your critical thinking skills. You get to just do it. You get to work the process, and you're in true Disneyland at this point. And so all of my ICU nurses and my ER nurses and my trauma nurses, all of you guys in critical care, this is when your fun starts at severe sepsis. Not so fun for the client now. Yeah, it's not looking good for them. When they go into severe sepsis, they're on the downward spiral. Okay. Was there a question, Dennis, or somebody?
Yeah, I had a question. For the septic workup, what was the temperature that they had to be above?
38 degrees Celsius.
Okay, thank you.
All right. So it will go into severe sepsis. Hopefully we can control it at sepsis with our antibiotics, because now in severe sepsis, we have organ dysfunction, hypoperfusion, hypotension. We're not just sitting around like on our phones, like, okay, all right. You know, we're already, as clinicians, we're hanging drips, we're getting lines in. You are running. I'm telling you guys. Wow, is 12 hours a busy day when you hit severe sepsis. You just consider yourself lucky if you can just go to the bathroom, okay? And then they're like, go take break. You're like, okay, I need to take a break. You know what you're going to come back to? What do you guys think you're going to come back to? They're going to send you off to a break. What are you going to come back to?
No antibiotics, hang.
Yeah, things that need to be hung, things that need to be verified, things that need to be called on. Like, is it a well-oiled machine? No, you have to call on a lot of your meds at the pharmacy. You got to call your farm tech too. Like, I've been waiting for this one. Can you deliver it as soon as possible? You start making deals. Like, please, I'll buy you a coffee if you bring mine first. You start making deals. You know, believe me, I always had a bunch of coffee cards in my pocket, because making these guys your friends is the right thing to do, by the way. The respiratory therapist, the lab, X-ray. Oh my God, I knew every X-ray by name. The farm techs, housekeepers. Oh, have you ever been in a situation where your trash can's overflowing and then the ground's overflowing next to the trash can? Like, having friends on the housekeeping team really aid you. Your sharp box is overflowing, your med waste box overflowing, because it gets pretty dicey. And so, yeah, I'll be like, but when you come back, you have all that stuff to do. And guess what, guys? Nothing's done unless it's charted, right? And who's going to chart it? Yeah. So maybe they're going to send you away if the charge nurse makes you, because do you think they care about you? No, they care about you getting overtime and they get yelled at by the managers, right? That's what they care about. They don't want to get over, they don't want to have to give you overtime. They want to send you to break before the 5-hour mark. Okay, so let's be real about this. Yeah, we might be valuable professionals in the healthcare system, but hospitals, we're numbers on their schedule. We're numbers on their schedule, okay? So yeah, they manage their budget accordingly. And that you'll learn about that when you get into your master's and if you want to go advanced, like doctoral too, you'll learn about hospital management and stuff like that too. So that'll all play into that. But yeah, you have all that charting to do. All right, so hopefully we can stop it here, because if it goes into shock, oh, wow. You might have epi hanging by now. You might have dopa hanging. You might have dobutamine. You might have Millerone for afterload reducer. You might have TPN lipids. You're not going to want them to do anything. Okay, you're going to want them to be basically in a medical induced coma. So we're going to start opiates. We're going to start benzos. What else? It could be anything. It's not unlike to have 12 different drips hanging at one time. On top of that, you're sitting over there drawing up, pushing it, drawing up, pushing it. You're just trying to get it in as fast as you can. Okay? Because they are in shock at this point. How do you know if you're giving too much? You can't give too much when they're in shock. It's impossible to give too much when they're in shock. If their vital signs say they need it, then you need to give it. And so how do you know if their vital signs say they need it? What is our measurement? If you don't have a nice CVP line up there, your central venous pressure line, if you don't have a line transducer central line that reads the central venous pressure, or CVP, that's our volume status, right? You guys know that, right? Anybody know that? Anyways, there you go. Now you do know that. Your CVP is for volume. Okay. Why do we transduce our venous system? It's for volume. We can look at our blood pressure. Okay. So what on the blood pressure is going to tell us if we're hydrated or not?
Like if it's like low, it means they're not hydrated.
Good, low blood pressure is good. That's definitely shock, right? Hypotension. But on the blood pressure measurement itself, what are we looking at? It gives us an idea of fluid status. It's a fast, dirty way for a good bedside clinician to tell if we're going in the right direction or if we need to improve what we're doing.
Is it the MAP?
The mean arterial pressure is very useful in determining consistency of your vital signs, but it's not what I'm looking for. But it is a very important thing to follow. In fact, all of the NICUs and for smaller infants, we use MAP instead of systolic or diastolic. It's MAP. But that's not what I'm looking for. So you have your systolic, you have your diastolic, and the difference between the two is what you call your pulse pressure. And it's your pulse pressure measurement that tells you your fluid volume status. Okay. And that's a quick, dirty way. So when we're resuscitating, we're pushing that fluid. We're going to have an art line. We're going to have a catheter in the artery, usually the radial artery, and it's going to be transduced, and we're going to see waveform. We're going to see direct measurements, right? And we're going to see blood pressure in real time. And so as we're pushing this, we're going to watch that pulse pressure. And we're going to make sure that we keep that greater than 20. Because if it starts to fall less than 20, we need to keep pushing it more and pushing it faster. Okay. So we're just pushing it in. If we can't stop it, then it's going to go into mods. We're at the point of no return at this point. You better get your bag and tag ready because you're going to be doing postmortem care after this. When they start failing 2 or more organs, guys, it's just extremely devastating to the body. And 9 times out of 10, they're just not going to recover. So there it is again. I like this one. It's a nice, quick, just fast way to look at sepsis and septic shock. I like things like this. I had a bedside folder, a backpack, a work backpack. I had work shoes. I didn't bring anything in the house. I left it either at the job or in my trunk. But I take this into work. And this is a great way to pull out these resources like this and kind of follow along the flow chart where you're going and what you need to do, and kind of gives you a quick refresher. So how do we manage it? We have to give antibiotics within 1 hour, even if cultures have not been drawn. And so you might be sitting there saying, oh, piece of cake, right? That's a no-brainer. Got this one. Yeah, I can draw, I can do a sterile in and out catheter, get your urine culture. I could get a sterile respiratory culture. I could get your sterile blood culture. I can even put in an IV within 20 minutes. Okay. That's not a problem. The problem comes in now adding sepsis to the picture, because sepsis, remember, the vessels are going to dilate out. And they're going to leak out volume. So that means they're going to collapse. They're going to be real floppy. They're going to collapse. They will not be very easy to cannulate. And so when it comes to cannulating those veins, it's going to be very, very difficult. And this is where you got to put your eagle in check. If you try 3 times, it's time to phone a friend. Say, hey, I tried this 3 times and I can't get blood from this client, this guy here. Could you do it? I've seen times when it took 12, 14 sticks to get IV access or to get blood from them. Okay. It's not such an easy process. It's not. And it has nothing to do with your ability to draw or cannulate these veins. It's sometimes it just takes different eyes and a different hand to do it. And so cardiac kids and septic kids are the worst. Okay, the worst. So if you're at the 1 hour, so okay, your doctor, you chart your 38, your doctor comes in, they see, or you're going to call the doc, hey doc, I just got a 38.1. He has this, this, and this. And he's going to say, okay, start your septic workup. I'm going to start putting in orders now. As soon as they write that order for the antibiotics, which they will, you're on the clock. You might as well start your countdown timer, because you got 1 hour until you got to give that antibiotic, even if you don't have cultures done. Okay. It is best practice, obviously. It's best practice to get your cultures before you give antibiotics. But if you can't get blood, then we're going to have to give the antibiotics first and then keep working on the cultures, and hopefully you get them soon. Because we're going to have to support these failing organs. We're going to have to correct a lot of electrolytes, make sure they oxygenate, and acid-base balance. Why do you think acid-base balance will be affected by this?
From increased respirations?
Decreased or increased?
Would it be increased respirations from like the hypovolemic shock?
Good, good. It would be increased respirations from acidosis. Yes, very good. What else?
Professor, I have a question regarding the antibiotics. I know you mentioned Vanco and Gent. Do we need to know like the trough times and any of that stuff?
Yes, you absolutely do need to know when you do troughs and when you do peaks, and then what antibiotics you do need to do those on. Yes, you do. So I'm talking about acid-base balance. So why will they have acid-base imbalance?
I think because you'd
I
have
heard-
decreased cardiac output, so it would be low like kidney perfusion, and then it wouldn't be, I guess, balancing.
Good, Christy. Good. You're outstanding. And although it's a little bit different from what you said, but it's really good. You're on the right track. So good job. Well, we have acid-base imbalance because, yeah, we have low cardiac output, so we don't have delivery of oxygen to the tissue. Remember, all of our cells need glycolysis for energy. We need to convert adenosine diphosphate to adenosine triphosphate, and that's our energy. And in this process, we get carbon dioxide, makes us acidotic, like Tristan said. They're going to breathe faster. And we get water. And we need oxygen because on the electron transport chain, it's the final electron acceptor. So for the process to continue on, we need oxygen there. And how do you get oxygen to the tissue if our cardiac output is, right? So yeah, we're going to have acidosis, right? Because we're going to have a lack of oxygen delivered to our tissue. Do you think they're going to stop? No, they're going to metabolize protein and they're going to go anaerobic metabolism. And anaerobic metabolism has a byproduct of lactate, which will cause lactic acidosis. And so, yeah, we're going to have bad acid-base imbalance. It's super fun. Do I get all my ICU nurses here? My mouth is just watering talking about this. It's like, yeah, this is good stuff right here. Love this stuff. It's like Jones is like getting a shot of just ecstasy. It's like, I can do this. Yeah. You know, you're a real ICU nurse if that's what you really strive to do in life. Yeah, God, I just wish during this pandemic too, if I wasn't teaching, man, I would volunteer to go into the ICUs just to do the sickest of the sickest. Like, yeah, send me there. I'd join registries and make $8,000 a week and just have the time of your life doing it. Yeah, I said that right. $8,000. I get text messages, I get emails all the time from registries offering me $8,000 a week to work in their ICUs, to work in their critical cares. And y'all will get the same things if you pass pediatrics. That little glitch there. Little glitch. You got to pass out these last few classes. But once you get into the workforce, yeah, you guys are going to be like, yeah, show me the money. Okay, no. We must continue. So I'm going to make now a bold statement that's going to offend probably one or two of you. But you know what? I'm a straight shooter. I say it how it is. So if anything else, you can count on me being a straight shooter. I'm going to say to you, if you do not know the pathway of blood flow through the heart, you will not be able to pass this quiz, which will be on week 5. If you do not know the pathway of blood flow through the heart, you will not be able to pass this quiz. You must make sure that that little detail is completely in your permanent memory, because you will not be able to think through these disease processes that I'm going to talk about unless you know what a normal heart does and how blood flows through it. Okay. And so you must be able to identify that it does come in through one of two ways, the inferior vena cava or the superior vena cava. And then it will enter into the right atrium, and it will collect in the right atrium, and it will stretch that right atrium. And based off Starling's gas law, it will eject with a more forceful contraction. And this is called your atrial kick. And that will eject through the tricuspid into your right ventricle. This right ventricle will receive that, dilate out, and it will go, and it will eject through the pulmonary valve to the pulmonary artery. And can somebody tell me why my venous blood is currently in an artery?
It's not oxygenated yet. So it needs to go to the lungs and get oxygen.
Because it's leaving the heart, right? And that's why it's in an artery. All blood leaving the heart is in an artery. Okay, so that's why it's in an artery. It's leaving the heart, but it's going to pick up oxygen. And it goes to the lungs, it picks up oxygen, gets rid of the carbon dioxide, it comes back through in a 4 vessels, 4 veins. Into the left atrium. The left atrium gathers that blood, ejects it, boom, through the through the mitral valve to the right, to the left ventricle. The left ventricle, boom, ejects it into the aortic valve, to the aortic arch, to the body. That's the pathway of blood flow. You do need to know that. You cannot pass without knowing that. Our fetal heart is different than our newborn heart in that it has different shunts in there. Can somebody tell me the 3 shunts in the fetal heart or body? This is where you,
Ductus arteriosus.
oh, good job, Tanya. So it's ductus arteriosus. Very good. That's one.
The ductus venosus, and then the foramen valve.
Good job. We got ductus arteriosus, foramen valve, and ductus venosus. Very good job. Can somebody tell me the hormone that keeps the ductus arteriosus open in fetal heart? Keeps it open. Hormone that keeps it open.
Is it like a female hormone? Like progesterone, estrogen, or something? No, I might be wrong.
Well, I know that females are great, and they are the most important thing on this earth, but not everything is about the girl. Although the girls are great, mind you, right? But it's called prostaglandin E, or PGE for short, that keeps it open. What is a hormone that's released that closes these ducts or shunts? It starts with an I. N. D. Indomethacin. Jesus. Like milking a rock for a response here. Will I ever get used to online teaching? Absolutely not. I hate every bit of it because you don't get, well, luckily I get some people talking in my class, but man, it's hard to make people talk. It really is difficult. Really, it's the hardest part to get responses because all you guys, well, all some people want to do is just watch. Anyways, indomethacin closes it. All right. So I'm going to present it like this. Learn it in 3 different categories. If you learn the 3 different categories, you'll know what each category does. If you're able to plug in these defects into each of those categories, you'll be able to critically think through any scenario and not even have to know exactly what actually an ASD is. So that's step number 1, is learn the 3 categories. Step number 2, learn what goes under those 3 categories. And step number 3, then learn each of the individual heart diseases in each of these categories. So for instance, acyanotic, they're all a left to right shunt, meaning the blood's going to go from the left side of the heart, which is here on me, over to the right side of the heart. Okay. That means, yes, it's going to recirculate through the lungs because it's going to the right side. So it's going to recirculate through the lungs. This is going to overwhelm the lungs. The lungs are going to say, hey, too much volume. They're going to start constricting. It's trying to slow the flow. Fluid's going to leak out into the low pressure pulmonary system. You're going to lose volume. You're going to have tachycardia because of the loss of volume. Your body's going to maintain cardiac output. It's stroke volume times heart rate. So you're going to see your heart rate go up. You're going to see your breathing rate go up. You're going to hear on auscultation rails or crackles, but you're going to see normal saturations. This is a left to right shunt. So that's what it looks like right there. Because they're not going to be able to breathe, they won't be able to gain weight, and they're not really going to want to eat. Okay. So it's going to be poor feeding, failure to thrive. And so all of these acyanotic defects are going to see these, if not exact, but very similar manifestations. That's why I say the first step is to learn the 3 categories. Second step, learn what goes under these 3 categories. Third step is to learn each of these disease processes. And now let's talk about those. Our first one is the ductus arteriosus. All right, so you guessed it, it's one of our fetal shunts that don't close. This is the very high left side of the heart, high systemic pressures. Their aorta is connected with the ductus arteriosus that did not close. When it does not close, it's called a patent ductus arteriosus. And so it's going to take the path of least resistance. The high pressure here will go into the low pressure pulmonary system, right where my cursor is, and it will add blood flow to your lungs. All right. So there's a couple of things we can do. We can first give them NSAIDs to close this. NSAIDs are first, not aspirin though, okay? Just other NSAIDs, but not aspirin. Second is we can use indomethacin or Indocin to close it. The problem with Indocin is it constricts other vessels in the body, and one that it targets is our GI tract, our intestinal blood flow is compromised with Indocin. And so they have things like necrotizing enterocolitis pop up if you give more than 2 doses. So really there's a limit on how much Indocin you can give them. Usually it's 2 doses. And then if that doesn't work, then we have to go in there and surgically clip it and close it or tie it off. And that way it'll be permanently fixed forever. And they're only going to fix this ductus arteriosus if they're symptomatic. And you're going to see that a lot in these acyanotic defects. If they're symptomatic, then they're going to go in there and fix it because, again, it's benefits versus risks. So, obviously. The next one is an ASD, it's an atrial septal defect. You have the foraminal valve that's right in between the left and right atrium, the Walsh. And the foraminal valve is a couple of leaves. The leaves are outwards towards the left side. And when the pressures on the left side become systemic after they are born, disconnected from placenta, they're born, their pressures on their left side become systemic. That closes these flaps. But sometimes those flaps don't close and they leave a partial opening. That's what you call a patent foraminal valve. Okay. That's a lot like an ASD. It's a hole between the atriums. But for this case, on an ASD, there's a complete lack of a foraminal valve there. There's nothing there. There's just a hole. And so this one's a little bit different scenario. They will need to go in there and surgically patch that. That's the only thing they can do with that. You cannot stretch cardiac tissue. They have to patch that one. Okay. So that's an atrial septal defect, or it's a defect in the atrial wall. The next defect is a defect in the ventricular wall. This is a VSD. But this is a little bit different in that it's your big systemic left ventricle here, which is arguably the one that's responsible for the most movement of blood through the whole entire body. And the hole is right there, so you have more pulmonary blood flow from a VSD than anything else, because it's just coming right off that beast right into the lungs. And so, yeah. But this is a little bit tricky because in fetal development, the wall, the ventricular, the septum is very thin. And oftentimes it does have defects in it. And as the muscle grows, then those defects are kind of like closed off. Okay, sealed off. And so that's why it's normal to have VSD for the first 6 months. And they won't treat it until at least 12 months until they know, okay, it's still there. It's a problem. We need to fix this. All right, one of those deals. So they won't technically do anything until 6 months, and then 12 months, they'll probably end up treating it if they have to, if the child is symptomatic. I've heard stories all the time, teenagers and freshmen in high school, they want to join a sports team because they don't want to do PE. And so they join a sports team, you don't have to do PE. And for the sports team, they require a physical. They go into their doc hears a murmur, does an echo. Lo and behold, they have a VSD. And the kid's like, I didn't even know I had that. So yeah, sometimes they live with these things, and as long as they're not symptomatic, they probably won't even know they have it. And that's okay. The next one is an AV canal. The AV canal is one large valve. It is the mitral and tricuspid all wrapped into one. And it is the most common defect in some cases, like trisomy 21. It is the most common heart defect in trisomy 21. It's why Downs or trisomy 21 kids are really super fun to take care of when they're older. But at birth, they're really difficult to take care of because they have this AV canal in most cases. And so this is what it looks like here, kind of overrides. So yeah, you guessed it. They're going to have to fix the defect here in the ventricular wall. They're going to have to reconstruct a new tricuspid. They're going to have to reconstruct a new mitral. So it does take a little bit of construction on the surgeon's part. And so this one and everyone I'm talking about today, we need to grow these kids. When they're born, their hearts are the size of a walnut or the size of their fist. And so we need tissue, and all of these cardiac kids will be born at a lower weight. And we need to just grow them to a certain weight. The cardiac surgeon needs at least 2,800 grams to work with. And that way the heart will be just big enough that they can do something about it. So although there's going to be a lot of, even though we know they have these problems, there's going to be a lot of waiting until they grow. And then we can do something about it. So very few of these defects I'll talk about today require immediate surgery on them. So that's AV canal. Now, I am a visual kind of guy, and I like certain websites. And one of the websites I like is Cincinnati Children's. They have great little videos on each of these defects. And so I pulled out the ones that I like, and I'm going to share those with you throughout this presentation today. This one's on AV canal. And
atrioventricular septal defect, AV canal. AV canal is a spectrum of relatively common congenital heart defects. It accounts for about 5% of all congenital heart disease and is most common in infants with Down syndrome. This is the view from the left atrium. An atrial septal defect, or ASD, is a completely open hole between the top chambers. This is the view inside the heart from the apex of the right ventricle. The mitral and tricuspid valves are combined into a single common AV valve. This is a ventricular septal defect, commonly referred to as a VSD. The lungs receive more blood flow than normal because of the ASD and VSD. Oxygen-poor blue blood. Oxygen-rich red blood. Since no blood flow is pumped to the lungs, the heart has to work harder to pump adequate blood to the body. This leads to heart failure symptoms, including fast breathing and poor weight gain. Once symptoms develop, surgery is typically necessary.
All right, so that's AV canal. The next defect is coarctation of the aorta. This will be the last one that I'm grouping in the acyanotic defects. Coarctation of the aorta is a narrowing of the aorta. This is one of the only defects you can actually diagnose by doing vital signs. So your blood pressure on your lower extremities will be less than your upper extremities. And that's because there's a narrowing here, and all that blood supply to your descending aorta that supplies all those organs, well, that's all compromised. So you actually see lower blood pressures on the lower extremities and higher on the upper extremities. You also see differences in the pulse and perfusion on the upper extremities versus your lower extremities too. So this is one of the few things you can actually diagnose from a set of vital signs. Now, the ductus arteriosus, if the ductus arteriosus is before, or if the narrowing is before the ductus arteriosus, meaning right where my cursor is here, if the ductus is on the downward side here, then we can use PGE and keep that open. What that will do is it'll help supply more blood flow to the lower extremities or to the descending, okay? But if the ductus is on the, if the narrowing is after the ductus, meaning the ductus is here where my cursor is, then it would be contraindicated to use PGE because then we're gonna overload the lungs, okay? So it matters where the ductus is in correlation to the narrowing is when we're gonna use PGE, prostaglandin E, to keep the ductus arteriosus open or not. They will need to do surgical repair and end-to-end repair on this one. And I do have a video on what it looks like, and I'll show you that one. And then after that, I'll give you guys a break. And this is coarctation of the aorta. This is what it looks like.
Coarctation of the aorta. Coarctation of the aorta refers to a narrowing of the main blood vessel carrying oxygen-rich blood from the heart to the body. The vessels before the coarctation see higher blood pressure than those after. Coarctation can sometimes be detected by differences in the blood pressure in the arms and legs. The degree of the narrowing determines how soon intervention is needed. Severe coarctation of the aorta is often found in the first few weeks of life. However, a less severe coarctation may go undiscovered for years.
All right, that's coarctation of the aorta. I'm going to give everybody a break, take a 15-minute break. We're going to start again at 9:25. So take a break, come back at 9:25, and we'll start right in on our cyanotic defects.
Bitcoin, the best money we've ever had. With a different kind of money comes a different kind of card. Crypto.com Visa card, powered by crypto. Reserve yours now. Steph's current Warriors even better than the 2015 or 2016 games?
Yes, they are. 4 games like that in their career. Yeah. He just had a lot of guys that's going to. What's up, guys? Welcome back to the channel, man. Welcome back to the channel. Today's video, man, this is the last time I'll be starting up this scat pack. But yeah, man, they ready to come get the car. I'm actually about to go to the store. This gonna be the last little drive before they pick up the car, man. Bittersweet situation, like I said before. I'm gonna miss my scat, but gonna give me a Hellcat, man. Well, at least that's the plan anyway. We're gonna leave the options open, man. See what's next for me. Like I say, man, I enjoyed this car. Winter time is coming. I wasn't gonna be driving it that much anyway. It's really not that big a deal. I'm working on getting me a little commuter car right now. I'm actually after they pick up the car, I'm actually gonna go and look at a couple cars. It's crazy, man. It's like I just got this car.
A video of Lee Jung-jae from Squid Game's press conference in the US went viral earlier because of the attitude that the Korean actor has shown towards a reporter that interviewed him while they're on the red carpet. The reporter asked Lee Jung-jae how it feels to be famous all of a sudden after Squid Game. Netizens called the reporter an ignorant because Lee Jung-jae didn't suddenly become famous because of the Netflix series, but he's been one of the most famous actor in Korea for many decades now. Netizens stated that the reporter should have researched first about the actor before her interview, so she wouldn't look ignorant. But Lee Jung-jae showed his humble side when he kindly answered the woman her question, even though he knows for himself that he's been famous for a long time.
For you, I'm sure you can't.
밖에 너무 유명해지셔서 right? Indeed, the biggest change has to be how I'm so recognized by everybody everywhere, and even in the United States at that. So when I would go to restaurants or out in the streets, I get recognized by so many people and really feel like we really
Years away.
get big.
Meanwhile, season 2 has been confirmed by Squid Game's director Hwang Dong-hyuk, though the sequel to Netflix's most popular title to date could still be years away. So what do you think about this? Please let me know in the comments section.
See, man, it's like I just got this car. I'm gonna miss the old wide body scat. I'm gonna be able to save my money a little bit. But like I said, man, I'm gonna lease my Hellcat. So it's all good, man. 2024, whenever they do come out with the electric car, I'm probably gonna get that just to see how it is. Something different on the channel. We got a lot coming to the channel, man. Stay tuned. So we're gonna get a couple last little pulls in the scat before they come and get it. Joe sliding all over the place, man. I needed some tires on this joint, man. So that's on them now. I ain't doing that to this joint. This car is gone. This car all over the place. There's no way I could drive this car in the wintertime, especially with the tires I got on here now. This joint it's like I almost like I was riding on ice, man. Yeah, man. It's crazy, man. I never thought I'd be selling this car this soon, and things will be happening the way they're happening, man. I'll be thinking about getting me a Hellcat, man. I'm telling you, man, God is good, bro. You just never know what's in store. Just gotta continue to work hard, manifest your dreams, man. You know, you gotta speak it into existence. I truly believe in that, man. But again, guys, oh man, what's going on here? Look like the police up here doing something. Accident. Oh yeah, you got to pull the white caught a motorcycle by him over or something. That's crazy. I'm excited, guys, for the future. Can't wait to take delivery of whatever vehicle I end up getting. She gone. She gone. She gone. They gotta take it to where they gonna ship it. Alright, guys, so that's it, man. The car's gone. I was gonna film a little bit more, but they didn't even bring the tow truck down here. It was an accident up the street from the house, so parked there. But anyway, man, so it's a done deal with the scat. Happy and excited for it.
So that will be the end of our acyanotic defects. Next, we're going to move on to our cyanotic defects. And our cyanotic defects will be a right to left shunt. And this will mean that your blood is therefore bypassing your lungs. Therefore, you're going to have that cyanosis. So your cyanotic defects will all have cyanosis. Polycythemia because you have cyanosis, or you have hypoxemia because, again, your blood is bypassing your lungs. It's going from the right side of your heart right to the left side and not going through the lungs first. Okay. You're going to also see a pump failure type of situation. So you're going to see delayed capillary refill. And of course, they won't be able to eat if they can't breathe. So poor feeding. All right. So let's talk about cyanotic defects, or a right to left shunt. The first one is pulmonary stenosis. Now, this is the mild one. It's a narrowing of the pulmonary valve. The narrowing is either the valve or it's right above or below the valve. So now I'm going to introduce cardiac cath. Cardiac cath will be important for all of these cyanotic defects, and it will also be important for our mixed defects too. So you're going to see cardiac cath a lot. So what are they going to do about this? It's a narrowing of the pulmonary valve. They're going to take a catheter into the femoral vein in most cases. They're going to thread it up into the right atrium. They're going to loop it through the tricuspid into the right ventricle. They're going to get it positioned right over that pulmonary valve. They're going to inflate a balloon. And they're going to do balloon dilation of that pulmonary valve. Hopefully that stretches that tissue out enough that blood flow now can go through the pulmonary valve, and lo and behold, we're fixed. Well, if that doesn't work, then they're going to have to do a valve replacement there. That would be the worst of both of the scenarios. So pulmonary stenosis is kind of straightforward. I'm not going to show you a video on that one. You can kind of visualize that it's just the pulmonary valve that it affects. The next is pulmonary atresia. Now it gets a little bit more difficult in that now there is no valve at all. There's tissue covering that. But it comes with an ASD and a VSD. So this is what's happening here. You have your big VSD that's going to allow mixing. You have your big ASD that's going to allow mixing. So you got mixing, but you have no way for it to go into the pulmonary artery because there's no valve. There's actually tissue covering that opening. So how are you going to get blood into the lungs? Well, you're going to need to use PGE, prostaglandin E, to keep the ductus arteriosus open so you can get blood flow to the lungs. Okay, so that's how this is going to work. So you have your blood here in your right atrium. It's going to mix with your left side. Okay, so you got mixing. Then it's going to be ejected through your pulmonary, your aorta. It's going to come, follow the path of least resistance. Since there will be no pressure in the pulmonary artery, it's going to shunt a lot of blood here. And that way we can get blood going through our lungs. So you need PGE to keep the PDA open on pulmonary atresia because there is no pulmonary valve. All right. Notice the size of the right ventricle, okay? Because the next one we're going to talk about is tricuspid atresia, meaning there's no tricuspid valve. There's absolutely no valve here, but look at the size of the right ventricle. It significantly is decreased or compromised because in development, there was never blood in there to dilate that right ventricle, so it does become underformed. So you have a very small right ventricle, although there is a right ventricle there. It's not absent, it's just really small. You have no way for it to get to that right side. So thankfully, there's a ASD there in most cases. We have to make sure there's at least an ASD, atrial septal defect, a patent foraminal valve, or we have to take them to cath and do a balloon atrial septostomy. Okay, so there has to be a connection here. In other words, so if there's not an ASD and there's not a patent foraminal valve, meaning a way for these two sides to mix, then we're going to have to take them down to cath. They're going to thread a catheter up again and pop it through that opening, and they're going to inflate the balloon, and then they'll pull it back through, and they'll make an opening there. We need that mixing to take place between the two sides. That's the only way we're going to get blood from the right side to the left side. Okay, so now that we got blood to the left side, it mixes over there. It mixes over there on the left side. It ejects through the VSD here into the right ventricle. But you can see that opening is small and that ventricle is small. So we need to help out the lungs. We need more blood flow to the lungs. So what do? We use prostaglandin E to keep the ductus arteriosus open. So this will allow more blood flow to the lungs. So from this defect and from the ductus arteriosus, we should get enough blood flow through the lungs then, and we can keep them going until they have to fix it all. Okay, and it's obviously a series of surgical repairs. They're going to have to reconstruct a tricuspid. They're going to have to close the septal defect and the atrium, the septal defect in the ventricles. So it is a few steps for the surgical correction. And again, a lot of these defects, we're going to let them with it until we can get them big enough so they can survive the surgery. Okay, so they will have to live with this and this type of blood flow until they gain enough weight. The next one is tetralogy of Fallot, and this is our last cyanotic defect. Okay, tetralogy of Fallot is one of the most common. It is not the most common. The most common is a VSD, but tetralogy of Fallot is one of the most common. It has 4 defects all wrapped into one. That's pulmonary stenosis or a stenotic pulmonary valve. It has right ventricular enlargement. So you can see how it's very large here on the right side. It has VSD. So you see the hole in between the ventricles. And it has an overriding aorta. So you see the septums here. And you see the aorta kind of goes on to the right side and left side. That's what we call our overriding aorta. Now, something unique about tetralogy of Fallot is that it has a unique radiographic signature to it, and that it looks like a boot on X-ray. And sometimes you'll hear the terminology boot-shaped heart. And if you see that, you'll know that it's tetralogy of Fallot they're talking about, because it has that characteristic boot-shaped heart look to it. I'm going to show you what it looks like now on this one. And this is going to be tetralogy of Fallot. And this is our last of our cyanotic defects. And again, these are all right to left shunts. These are all right to left shunts. Polycythemia, poor feeding, poor capillary flow because of the cardiac outputs decreased. And this is the last of those 4.
Tetralogy of Fallot. Tetralogy is one of the most common congenital heart defects. It has 4 main features: ventricular septal defect, or VSD, overriding aorta, pulmonary stenosis, right ventricular hypertrophy. This is a view from inside the right ventricle. This is a ventricular septal defect, commonly referred to as a VSD. A VSD is a large hole between the left and right ventricles. This allows abnormal flow of oxygen-poor blue blood into the left ventricle. The right ventricular outflow is obstructed. Blood flow to the lungs. This is referred to as pulmonary stenosis. The aortic valve is enlarged and overrides the VSD, which makes it easier for oxygen-poor blood to enter the systemic circulation. The right ventricular wall thickens or hypertrophies due to outflow obstruction. Oxygen-poor blue blood, oxygen-rich red blood, mixed purple blood. This is VSD blood shunting. This combination of abnormalities can result in decreased oxygen in the systemic circulation, sometimes resulting in patients appearing cyanotic or a bluish appearance.
All right, so that's tetralogy of Fallot. And moving right along, going into our mixed defects now. This means that it's going back and forth. They could have cyanosis. They could have regular saturations. They're going to have all the other combination of the manifestations. So the first one is transposition of the great arteries. Transposition, meaning they're transposed, meaning that the aorta is coming off the right ventricle and the pulmonary artery is coming off of the left ventricle. And so they're transposed, meaning that you're going to potentially have cyanotic blood going right to the body. So we do need that atrial septum to be opened up. Again, either an ASD is preferred or a patent foraminal valve. We do need some type of communication between the two sides, because if not, we're going to be ejecting cyanotic, deoxygenated blood right to our body. So we do need that opened up. If there is no ASD or patent foraminal valve, then we're going to have to take them to cath lab, and they're going to have to do the septostomy, again with the balloon, and open one up for them so we can get mixing. We want mixing. Mixing is better than nothing. If we get that opened up, then we can have mixing between the two atriums. Then we can have mixed blood go into the left ventricle, and the mixing will go also into the right ventricle. And so therefore we can get mixed blood going to the heart. We also will want to keep the ductus open, because this ductus coming off the left ventricle is mixed blood too. So if we can shunt blood over, kind of like a left to right shunt here, shunt blood over to that side, we can get even more mixed blood being ejected to the body. So it'll help out with pulses and stuff. So we do want to keep the ductus open. We do want to make sure that that atrial septum is opened up. Now, this one also has a unique radiographic finding in that it looks like an egg on the x-ray. So it has the terminology egg-shaped heart. If you see egg-shaped heart, then you're pretty much certain that it's going to be transposition of the great arteries. All right, so this is what it looks like in transposition of the great arteries. In that the great arteries are transposed.
Transposition of the great arteries. transposition of the great arteries occurs when the aorta and pulmonary artery are transposed. In a normal heart, blue oxygen-poor blood returns to the body through the right atrium and goes to the lungs via the pulmonary artery. Red oxygen-rich blood then returns to the left atrium, enters the left ventricle, and goes to the body via the aorta. In transposition, blue oxygen-poor blood returns to the body through the right atrium, enters the right ventricle, and goes to the body via the aorta, bypassing the lungs. Red oxygen-rich blood is pumped back into the lungs via the pulmonary artery without going to the body. As a result, newborns with TGA are born with a bluish appearance, known as cyanosis. In TGA, there needs to be a connection between the right and left sides of the heart so oxygen-rich blood can reach the body. Most commonly, this occurs between the atria, or upper chambers of the heart. This is inside of the right atrium. In a normal heart, this hole is closed to separate blood in the two upper chambers. A patent foramen ovale, or PFO, is a partially closed connection between the top chambers. An atrial septal defect, or ASD, is a completely open hole between the top chambers. In TGA, there needs to be an ASD or PFO so that oxygen-rich blood can reach the body. In order to establish normal blood flow, surgery is needed in the first couple weeks of life. This involves switching the aorta and pulmonary artery to their normal location.
All right, that's transposition of the great arteries. The next one is truncus arteriosus. I like to think of this one as the elephant's trunk. It's a single large vessel that provides all the circulation. So here's what it looks like right here. It's the aorta and pulmonary artery all in one single vessel. It has a large VSD with it. The problem with this one is the surgeons will have to reconstruct a new aorta and reconstruct a new pulmonary artery. They'll also have to reconstruct the aortic valve and the pulmonary valve. And they also have to fix the hole in the ventricles. So there is a lot of stuff going on. So anytime the surgeons will make a incision and suture it back together, that tissue will be weak. That tissue will have scar tissue. That tissue won't have the same tensile strength. It won't have the same flexibility. So the aorta and pulmonary artery, because it has to be reconstructed, now are not able to be vasoactive, meaning they can't dilate or constrict. And so therefore, these kids with truncus arteriosus, even though they can be fixed, they can never participate in any strenuous activities because those vessels, the pulmonary artery and the aorta artery, they won't be vasoactive. They're going to be very stiff and kind of a fixed vessel at that point. But at least they'll have their life, right? So we have to look at the positive side. This is what it looks like. This is truncus arteriosus.
Truncus arteriosus. Truncus arteriosus refers to a common trunk that includes both the pulmonary artery and aorta. A hole, called a VSD, between the bottom chambers allows blood to mix before entering the common trunk. The mixed blood then goes to the body and lungs. To the body, through the aorta. To the lungs, through the pulmonary artery. As the baby ages, the blood pressure in the lungs drop, resulting in too much blood going to the lungs and causing congestive heart failure. Surgery is necessary to separate the pulmonary artery from the aorta.
All right, so that is truncus arteriosus. I like to think of it as a common elephant trunk. And we're going to move on to our next one, which is our total anonymous pulmonary venous return, or TAPVR for short. Remember, I said that 4 vessels have to return back to the left atrium. In this case, all 4 of those vessels are going into an innominate vein, and that innominate vein is going right back over to the right side to the superior vena cava. So this is what it looks like here. Instead of those 4 pulmonary veins returning back to the left atrium, they're all going to an innominate vein, and that innominate vein is going right into the superior vena cava. We will need to keep the ductus arteriosus open for more pulmonary blood flow. And this is kind of what it looks like on this one. This is a total anonymous pulmonary venous return. And again, all 4 of those vessels are going back to the right side of the heart, not the left side. This is what it looks like.
Total anomalous pulmonary venous return, TAPVR. TAPVR is a congenital defect in which the pulmonary veins do not connect normally to the left atrium. Normally, the pulmonary veins return oxygen-rich blood to the left atrium. Instead, they drain oxygen-rich blood to the superior vena cava by an abnormal or anomalous connecting vein. This results in oxygen-rich blood not going directly to the body. This is a view from inside the right atrium. This is an atrial septal defect, or ASD. An ASD is a hole between the top chambers of the heart that allows oxygen-rich blood to enter the body's circulation. Blood flow in TAPVR. oxygen-rich red blood enters the pulmonary veins. Then it mixes with oxygen-poor blue blood in the superior vena cava. Some of the mixed blood supply travels through the ASD into the left atrium. Babies with PVR will need surgery within the first few weeks of life.
All right, that's TAPVR. And our last one is hypoplastic left heart syndrome. This is our only single ventricular kid. This is our only single ventricular case. And these ones are all terminal diagnoses, meaning we can only do palliative surgeries. As soon as they're born with hypoplastic left heart syndrome, they are automatically put on a transplant list. And some of these guys wait until their body just fails them and they end up dying on the list. Some will get a heart. Hopefully those lucky ones will get a heart. But unfortunately, it's a terminal. So if they don't get a heart, then they will pass away. We're doing better with hypoplastic left heart syndrome, and that we can keep these children alive into their late 20s now. So what is it? Well, there is no left ventricle. In fact, the left ventricle is just like a thumb. It's just there. It's not functional at all. So it's all one side ventricle. So you do need the openings between the aortas for mixing to take place. And we are completely relying on the ductus arteriosus to do all of the blood supply to the body. And because the aorta is coming off the left ventricle is not there. So therefore, all of our blood supply to the heart body is through the ductus arteriosus. So we do need to keep the ductus arteriosus open at birth. And with the atrial septal defect that it comes with, we will have ability for mixing to take place, and then we can inject blood to the rest of the body. There are 3 palliative surgeries that will give them permanent shunts in their body. So we can't do anything about the left ventricle, but we can give them 3 permanent shunts. That way we don't have to solely rely on the ductus arteriosus. So we do a Glenn, a Fontaine, and a Norwood. A Glenn, Fontaine, and a Norwood. And we do those at different times. So this is hypoplastic left heart syndrome. It is our only single ventricular kid, and they are terminal diagnoses. So all of these children with cardiac problems or congenital heart disease will have to be on a cardiopulmonary monitor. We will need to make sure that their oxygenation remains within their physician ordered range. Remember when I talked about retinopathy of prematurity last week? And I said that premature babies, we have premature SAT parameters because we allow for permissive hypoxemia. And this is the same with cardiac kids. So cardiac kids, we allow permissive hypoxemia, and that we keep the saturations anywhere from 82 to 85%. 82 to 85%. Okay. By doing so, we will minimize the effect that oxygen has on the pulmonary vasculature. So oxygen is a very potent pulmonary vasodilator, and it'll vasodilate out those pulmonary arteries, thus allowing more blood flow to go to the lungs. And that means that more blood more fluid would go over into the alveolar sacs. It'll diffuse over into the from diffusion. It'll diffuse over into the alveolar sacs because that's a low pressure system. Not only that, but this increase of blood flow will drop the systemic pressure, thus making the heart work harder. So always be mindful of how much oxygen you're using. Preferred is that we don't use any extra oxygen. And we can even tolerate them being in the SATs of high 70s before you have to turn up oxygen, right? So use oxygen as your very last resort. If you turn up your oxygen and your SATs go back up, make sure you turn it off right away. Because if a cardiac surgeon happens by that bedside and they see that you have them on oxygen and they look at the SATs and it's in the high 80s and low 90s, they're going to do one thing. They're going to just turn around, go right out to the charge nurse or your manager and write you up on the spot. They get very, very upset with that because it puts more work on the heart, plus it floods our lungs. Thus, they're going to work harder, they're going to breathe harder, they're going to burn more calories, which takes us to our next nursing intervention for cardiac kids. We don't want them to cry for prolonged periods of time. What we want to do is we want to reduce their metabolic demand as much as possible, thus taking the work off the heart, thus not letting them cry, thus ensuring that they're fed on a regular basis. So we're going to basically, without being called medical induced coma, we're going to sedate, and we're going to heavily sedate, and we're going to give them opiates and benzos to do this. We want to keep them calm. We don't want them to cry. We don't want them to really just do anything. We just want them to sit there and grow, because that's what they need to do. We need to get them big enough until this cardiac surgeon can do the repairs. That means we're going to have somewhat of a very good IV access. So a PICC line, a Broviac in the right chest, subclavians, Cook catheters. We need some type of good central line because we're going to be given a lot of preload, afterload, contractility drugs, blood pressure drugs, our IV nutrition. For feeding, we want to keep up with a feeding schedule. We want to optimize our calories. So we're going to pull on dietary to help us with this. We're going to optimize, if mom's breastfeeding, we're going to pump mom's breast, or have mom pump her breast rather. And we're going to fortify that milk. We can take that milk from 20 calorie, which comes out of the breast. It's 20 calorie out of the breast. And we can fortify that up to 27 calories. By adding human milk fortifier to that. We want to optimize how many calories we get. And you might ask yourself, well, then why can't we just go to 100 calories per ounce? Well, there's a limit on how much we can feed to our kids. And then if we go over that limit, usually it's 27 calories our max. If you go over 27 calories, you go to 28 calories. They tend to have more feeding intolerance at that point. They just can't digest it. They just can't process it. It becomes a problem to them. They vomit a lot. They reflux a lot. And that would be contraindicated in what we want to do. So 27 calorie is our pretty much limit. So we use fortified breast milk. We can use 27 calorie formula, and we can add more stuff to it. So a common thing that we add to their feedings, which is in the form of an oil, is our medium chain triglycerides. It's not technically calories, but it's fat, and they get calories through fat. So it's a win-win situation. So it's easy for them to digest this. It's a different process to break fats down, and therefore they can tolerate it, and we can add that to their feedings. We can grow these children up, and we can get them to the weight they need to be so they can do the surgery. We will have to do a lot of education, preoperative, postoperative, lifelong care, right? Remember, truncus arteriosus, they can never participate in a strenuous activity. So lifelong care. You've seen that a lot of these will require cardiac cath. And this will be my last slide. So if you have not sent me your PowerPoint and you're presenting next, please send it to me when I go over this last slide. Send it to my email, like always, send it to my email. So if you're presenting today, send it to my email. All right. So cardiac cath, you see that most of our mixed defects, all of our cyanotic defects will require them to go to cardiac cath for one reason or another. So this means that we're going to have to do preoperative care. Our preoperative care is make them NPO 4 to 6 hours prior to the surgery, and they consider these surgeries. Make sure they're not allergic to any shellfish or iodine, because that's how they clean the site. And you want to mark the dorsalis pedis and the posterior tibular pulses on both extremities with a little surgical marker. And the reason for this is when they come back from OR, their pulses might be decreased and you might not be able to palpate them, or maybe you can palpate them, but having the X marks the spot, you'll know right where to go to palpate for those pulses. And also, if you need to use a Doppler on them, you know exactly where to position the transducer for the Doppler. So mark your posterior tibular pulse, mark your dorsalis pedis pulse preoperatively. Now, postoperatively, we want to make sure they stay on the cardiac monitor. We want to keep that extremity straight for at least 4 to 8 hours, 4 to 8 hours. And we want to make sure that the pulses are equal on both extremities. The cap refill is equal. The temperature is the same. They should be the same. They're going to come back with a dressing, a pressure dressing from surgery. Under no circumstances are you ever to remove this dressing until the doctor says it's okay to do so. That means you don't look under it, you don't take it off and replace it. You just leave it alone. Keep that extremity straight, keep that dressing on there. If there's sandbags on that, then keep the sandbags over it. If there's a pressure device over it, there's a lot of different devices that, like, you pump up and it squeezes it. Those are frequently used. Whatever the device is, you're not going to release it. You're not going to look under it. You're just going to keep it like it is until the doctor says it's okay to take it off. Now, if it starts bleeding, if that site starts bleeding, you must locate your site and put direct pressure above that site immediately. And you're going to hold that direct pressure until the bleeding stops. And I don't care if it's 30 minutes, you're holding that pressure until it stops. And then once it's stopped, you can put more dressing over the top, or you can put another sandbag over the top. You don't remove the dressing, you can reinforce it at that point, and you can put sandbags over it. And then after that, you call the doctor and get them over to the bedside. All right, guys, that's all I got for you today. Now we're going to do our 3 group presentations, our 3 presentations.